Hi, I'm Dr. Betty Maloney, a family physician from Minnesota. Lyme disease is a complex illness that's often misunderstood. To help people understand the infection and how it may affect them, I created the educational DVD series, Lessons in Lyme. It explains the science in layman's terms. Originally filmed in 2011, the information is still relevant. What you're about to see is a short clip from the series. Other clips are also available. I hope the information is helpful to you. I'll catch you on the other side. Now, to do all that tracking and gather those numbers, you have to decide what it is you're going to count. So what counts and what doesn't count. And to do that, we need to establish what's called the surveillance case definition. So whatever illness, you have to pick a way to define it, what you're going to count and what not. Now, from a philosophic viewpoint, surveillance case definitions can be of one of two types. They can be broad or narrow. And so I've made this little table to kind of go through the differences between taking a broad or narrow approach to your definition. When the case definition is broad, what's good about that is you're going to capture a lot of different types of that illness. So you'll have a wide disease spectrum. You'll know all the different ways that the illness shows up. And the good part about that is that it really will look a lot like what's walking into a doctor's offices. And you're going to get a lot of case numbers. So you have a lot of data to look at. The bad side is, included in all those case numbers are people that don't have the illness. And so we would say that that's a real disadvantage because you don't want to have those people in your group, or you might end up building strategies to treat a person who doesn't even have the illness you have in mind. And so there are some problems with having a broad definition. A narrow definition is like the polar opposite in a way, because your disease spectrum is going to be limited. You're going to find people maybe with just one or two presentations rather than that whole mix of possibilities. Now, what's nice about that is you've so clearly defined what is and isn't disease that it's much easier to study when you intervene. Because you're going to know that this person had my disease, I did this, and they got better. So I therefore know that doing this helps that disease. It's really great for clinical trials then. The trouble is the people that you finally recruit and say have your disease, they might not look much like the people that walk into a doctor's office. And so the evidence that you gain in your clinical trials might not be applicable to the people who come in for treatment. And so the problem there is we exclude true disease, and so we might be missing a lot of information. And I termed that we get silence. And so that's the philosophy of surveillance case definitions. Now, I know that people complain about the surveillance case definition in Lyme disease, and they think that that's the root of the problem. And let's go through that surveillance case definition. Now, this definition is new for 2011, and the CDC does not create these definitions. They're actually created by the Council of State and Territorial Epidemiologists, so CSTE. CDC has input, but they don't create it. The other interesting thing is that while within a state, doctors are mandated to report to their county or state health department, the states are voluntarily reporting to the CDC. States don't have to report. And what they report is not determined by the CDC. It's determined by the state's own regulations and laws. CDC might want them to report in a certain way, but that doesn't obligate the states to do that. And so when we think of the Lyme disease definition, there are clinical criteria and there are lab criteria. And here are the clinical. For early disease, it's centered on having an erythema migrans rash. And so people who have a flu syndrome and positive lab testing wouldn't really qualify. What intrigued me here is that it's required that the diagnosis be made by a physician. And in many parts of the country, more mid-levels, physician assistants and nurse practitioners are seeing patients. And so I wonder then if those patients would be reportable, because by this definition, they would need a physician to confirm it. And if you haven't been in an area that's known to have Lyme disease, you need to have positive labs. And I can tell you, in early Lyme disease, your odds of having a positive lab are less than 50%. Now, late Lyme disease is defined either by arthritis, and it has to be arthritis which comes and goes. It can have neurologic findings, either meningitis, inflammation of a cranial nerve, and the cranial nerves are those nerves that come off your brain and serve your head and neck regions. And the most common cranial nerve is problem that people recognize is Bell's palsy. And then you can have problems with your heart that's due to Lyme disease. And especially if it's with the electrical conduction system of your heart, then that would qualify for inclusion as a clinical, meeting the clinical criteria for the Lyme disease surveillance case definition. But it's not enough to meet the clinical criteria. There are lab criteria. So you need to have a positive culture or a positive two-tier testing, which is testing that looks for antibodies to the Lyme bacteria. What's new in the last few years is that if you have an IgM positive, it's only good if it's occurred in 30 days from the time of the bite for the first 30 days. But if you have a positive IgG at any time, that alone is sufficient. So you can, in essence, skip the first step test, the ELISA test, and just go for the positive Western blot. And then if you end up having a lumbar puncture or a spinal tap, if you have positive antibody there that's higher than what's in your blood, that also would qualify you on the basis of lab criteria. So to ultimately decide if someone's case meets the criteria for being in that special surveillance case group, here's what a confirmed case has to be. Erythema migrans in a place where we know that there's Lyme disease, or erythema migrans with a positive lab test. If you have a late manifestation of Lyme disease, you must have a positive lab test before your case would be counted as a surveillance case. If patients have other findings of Lyme disease that aren't on that list that I showed you, and they have positive blood work, then they can be reported as a probable case of Lyme disease. And that's also relatively new. That came on board in 2008. Suspected cases are either where you have an erythema migrans, but you have a negative lab test and you didn't have any known exposure. Or sometimes labs will have find positive test results and report them to the state. But if the state doesn't have any clinical information on the patient, then that case would be reported as a suspected. Pretty straightforward stuff, but even a little bit more detailed is that when we talk about exposure, especially for the erythema migrans patients, they're required to have a known exposure. You have had to have been in a tick habitat within 30 days before your rash started. And not only did it have to be in tick habitat, it had to be tick habitat in a county that's been declared to be endemic for Lyme. And endemic means that they've had 2 or more cases of Lyme coming from that county. And so even defining the surveillance case definition for Lyme is difficult. There's a lot of layers. And all of those layers at another level of complexity, and as you might guess, it makes that spectrum of disease quite narrow, certainly more narrow than what clinicians see in their offices. There are problems with the surveillance case definition and how they're reported. And perhaps one of the biggest one is simply the fact that they're not reported. We don't know how much underreporting there is. Some published studies found that for every case of Lyme disease, I believe this study was out of Wisconsin, that was reported, there were 3 that weren't. Out in the East, they found that for every case that was reported, there were 12 that went unreported. And those were all cases that would have met the surveillance case definition. The other problem is the recognition that the surveillance case definition numbers are not the same as the numbers we would see if we were including all of the clinical cases that physicians see. Because clearly people are treated for Lyme disease who don't meet the surveillance case definition. But we're not counting those people. Other problems is that not everyone adheres to the surveillance case definition. Remember, the states can report however they want, and some of them actually do. And so they might not report the way the CDC wants, or their reports might be incomplete. All erythema migrans rashes were not created equal. An EM in most of Minnesota, and certainly in our area, would definitely qualify you as a reportable case of Lyme disease. That's not true if you live in Georgia. So the same rash, take it to a different county, and you're going to have a different result in terms of whether or not it's reportable. And speaking of Georgia, I want to give you a little example about how the numbers can really vary and change. From 1982 to 88, there were only 62 cases of Lyme disease that met their surveillance case definition. Then look at that jump, 715 in this 1 year in 1989, followed by kind of a crash down to 161, still much higher than 10 years earlier. And so when we look at the 89 numbers, one of the questions we have to ask ourselves is why? Why did it go up in that year? Well, it could be that there was a change in local epidemiology. Maybe there really was a change in the ticks in that county or in that state. Or it could have been increased awareness because guess what? In 1989, there was a big educational campaign, not only for the public, but also for physicians. And so that awareness would have more people coming into physicians to be checked for Lyme and more physicians diagnosing and reporting Lyme. The other thing that was unique to 1989 was that the state offered free testing through their lab. And the lab had changed its threshold on the first line test, and so it made it a little bit more sensitive. So they were picking up more cases that way. So there were several factors that would explain that jump in 89. And the decline in 90 is also has some explanation because the state testing program went away. Also, the new national surveillance case definition came on board, and so that might have cut into some of the cases that were reported. But as you can see, just looking at the data from Georgia, many variables can affect what numbers are produced. And if we multiply that across the whole country, you could see why there might be big swings in reported cases. But the thing I think that bothers patients is that there's such a difference between the surveillance case definition and the clinical diagnosis of Lyme disease. And I think that Dr. Paul Mead, who's the epidemiologist for the CDC vector-borne division, he summed it up quite nicely in this statement, in that a clinical diagnosis is for treating patients, an individual patient. And so we're really going to zero in on the details of that person's history. Surveillance case definitions have an entirely different purpose. Their job is to try to standardize things so that we can gather data. They are not interested in taking care of patients. And so they aren't going to want to find and treat everybody. They want to be specific. And Dr. Mead goes on to say that physicians are appropriately erring on the side of overdiagnosis. They're being sensitive. If a case looks enough like Lyme, you should treat it as such. That's appropriate. But surveillance cases are erring on the side of specificity so that they aren't capturing illnesses, calling them Lyme when they're really something else. And so really, the problem in Lyme disease in terms of the numbers is not with the surveillance case definition. The real problem is that the surveillance case definition is being used as the yardstick to measure who has Lyme disease and who doesn't. And it was never intended to be used in a clinical way. And so the problem there is that we're applying that definition in the wrong situations. Having said all that, we'll look at the numbers. Because these numbers maybe don't have quantitative value, and so I don't want you to hang your hat on 38,468 cases, but they have qualitative value because we can still follow trends in the numbers. And so here are the numbers for 2009. You can see that they were reported as confirmed and probable. And when you look at the map of the U.S., what that represents is for every patient that's a reportable case, they put a little dot in the county where they live. And so if you've had 2 or more cases in your county, now you're labeled an endemic county. And so looking at the map, your eyes, of course, drawn to the East Coast and then to the Midwest. But if you scan over to the West Coast, there's pockets in the Seattle area and actually down that coastline, San Francisco. But look and follow the Gulf Coast. There's Lyme disease there. And so Lyme is not just a Midwest, East Coast illness. But there are what I like to call Lyme belts. And so looking in the Midwest, you can see when we say that Minnesota and Wisconsin have Lyme disease, it's not all of Minnesota, it's not all of Wisconsin. So you can see that nice band that kind of extends up. And so Lyme belts exist. And not only do they exist on a regional level, they exist on a state level, and even within counties. You'll have some areas where there's a lot more Lyme, and then other areas where there might be no Lyme. And they could be separated by just a couple miles. Now, cases can be, the statistics that we look at, we can report them in many different ways. And so here you see cases by month. And naturally, the summer months are higher because that's when the nymphs are biting in late spring, and a month later up show the cases. Or we can look at cases by age. And here we see that kids, 5 to 9, are the highest risk group for Lyme disease, and then followed by people in middle age. The young, healthy hikers and bikers and kayakers and all those outdoors people in their 20s and 30s, for some reason, don't seem to be getting Lyme disease. And I think that would be a great place to investigate the whys. Looking at Lyme by body system can be helpful. It's interesting that if you look at it, it's pretty stable, so there hasn't been a big change. Same number or percentage of people are getting the rash, which is roughly 70%. And then there's arthritic Lyme. That third line from the bottom is, or from the top rather, is people who have neurologic disease. I find this graph very helpful because some physicians are starting to claim that we're doing a better job of finding Lyme early and treating it. And I would say I don't think that's the case, because if we really were finding Lyme earlier and preventing late disease, why haven't we seen that reflected in cases of arthritis and neurologic Lyme? And so I think we can use this data to challenge some of the concepts that people are putting out there. And here's Lyme reported by year, kind of that steady upward climb. And the hatched areas on 2008 and 2009 reflect the change in the disease reporting, where now cases can be reported as probable. And so to summarize the statistics of Lyme disease, we know that the surveillance case definition is helpful in that it allows us to track this illness over time, and in a way that we know we're comparing apples to apples. But it's narrow, and that causes problems because there's a lot of patients with Lyme disease who aren't getting counted. Hello again. Thanks for watching. Please share this clip with your family and friends. Be sure to check back to see other newly released videos. For more information, check out our entire website, www.partnershipfortick-borne-diseases-education.org. Like us on Facebook and follow us on Twitter. Once again, thank you.